Well, around 2001 or 2002, Calgary leapt at this notion that TIA was dangerous and that there should be something, there could be something done, and built something called a TIA reference unit, where they took all the TIAs, brought them into hospital, as only Alberta could do with their resources, and managed them quickly and effectively and treated them. And so out here in the poor cousin in British Columbia, we decided that we could try and do the same thing, but that we couldn't admit them into a hospital bed because that was far too expensive. So we put them into lazy boy chairs where we could keep them for the day and do all of the investigations and then send them home and not have to pay for their supper. And so that was called the Stroke Rapid Assessment Unit, and that is along the same lines as what is being evolved around the province now. But before telling you more about what's happening around the province, I want to show you the results of a study that was done in Oxford in conjunction with the registry data that I showed you before. So in addition to finding out how much TIA was happening in Oxford, they built a unit like ours at the same time as we did in 2004. And they published the results of the impact of that trial in something called the Express study. And what that did was to look at two things, two phases. In phase one, they ran a unit that would actually be pretty good for any Canadian city. They got people in to see a specialist, they did some tests, they got them operated on, they gave a letter to the family doctor that they should be started on this drug or that drug. But in the first phase, they did it in a rather slow fashion. They just sent letters out to the GPs. They didn't actually start the patient on drugs. And I'll show you some of the other differences. And in the second phase, they revved it right up and did everything as quickly as they could. And the results were that in the first phase, when they did it in a sort of lackadaisical fashion, the stroke rate at 90 days was still 10%. But when they speeded it up in phase 2, which is the blue line at the bottom of that curve, the stroke rate at 90 days was 2%. So they had an 8% absolute risk reduction in 90 days, which in terms of healthcare interventions is huge. There's very little that you can do out there these days that can have that degree of impact. And the only difference between phase 1 and phase 2 were things like this. So in the first phase, 23% of the patients got to the clinic within 24 hours of referral, whereas in the second phase, 60% did. And in the first phase, nobody got a carotid endarterectomy within a week, and in the second phase, almost half of them did. And the data, by the way, for carotid endarterectomy is if you're going to do it, you need to do it within 2 weeks. Otherwise, maybe there's not a lot of point. And here, in terms of starting them on the various drugs, statin, clopidogrel, blood pressure drugs and such, in the first phase, they told the GP, and although you can't see the time base, that's the purple curve, and it shows that over the course of 90 days, gradually those patients got started on drug. Whereas in the second phase, it's the blue curve, and they got started on drug immediately. So I think the message to deliver here is that you can build a unit, but if you don't do things really rapidly, it may not be any value. I want to just kind of give you some indication of what the approximate impact of this kind of intervention might be compared to other interventions in your region. And I'll use data here from Vancouver Island. So in our stroke rapid assessment unit in year, I think in about the second or third year, we saw 910 patients, and that included lots of people who were mimics, because when they get sent to our unit, we don't know beforehand if they're a TIA or a mimic. We have to sort that out. So there are 910 patients of all denominations. And during that year, 30 people got treated with TPA, and our stroke ward managed 138 patients. I thought it was much more than that because it was a reasonably big ward, but people stick around for a long time. So there was only 138 patients. And if we look at the evidence for the impact of these different interventions and using the Oxford data to see how many strokes we prevented, presumably, and the reduction in death and disability by removing those strokes, then the stroke rapid assessment unit would have saved 20 people from death or disability. The TPA program would save 4 people, and our stroke ward would save 12 people. And the relative cost of those various interventions, I think the rapid assessment unit could conceivably be the cheapest. Because particularly in our first years, we ran it on a shoestring. So intervening rapidly potentially has the impact of having more impact than other interventions that you can unleash. This is data from the 2 hospitals in Victoria, and the first 3 are the years before the stroke unit opened, and the second 2 are the first 2 years of operation. And the drop in stroke admissions for the 2 years after we opened the unit was about 15%, 14 or 15%. So that we observed this large drop in stroke admissions after we opened our unit. We went ahead to sort of look in that in more detail and published on that, or at least we presented that in Stockholm this summer. But I'm just going to leap ahead because time is zooming through. If we looked at the years, now we've got, by the time we presented this, we had 4 years, 2005 up to 2008. And the first 2 years that we were open, we were open 5 days a week, and we're working overtime until all the patients were seen, sometimes 7 or 8 o'clock at night. And then in 2007, 2008, it was decided that nurses' overtime was costing the region too much money. And so they were put down to 4 days a week, 10 hours a day, rather than 5 days a week, 8 hours a day. And as a result, the number of patients who were seen quickly dropped, and the median wait time for our unit went from 2.7 days up to 4.4 days. And I don't know if it's related or not, but our impact, at least the stroke admission rates, bounced back up again. And in fact, if you look and you put the stroke admission rates on the island and you overlap them delay in getting to the unit, you see the green bars tell you how quickly we got people to the unit. The shortest one there is 2.7 days, and it goes up to 3.4, 4.4. There seems to be a relationship between how quickly we worked and how many people got admitted with stroke in southern Vancouver Island. And in fact, that's the relationship, a pretty close relationship between the median delay and the stroke admissions on Vancouver Island. So we had to conclude that there may be a time threshold that confers efficacy on one of these units. It may not be good enough just to set it up, as the Oxford study suggested, and there may be some important thresholds. We can't really conclude that from this data because we don't know if this is a causal effect or not.